after, so we'll get started. For those that'll watch the recording and maybe haven't been to a colloquium before, my name is Alex Lyon. I'm the Associate Director of the Evans Center for the Integration of Religious and Spiritual Values in Health at IU Health. And this is our quarterly spirituality colloquium that we get to welcome scholars, researchers doing work at the intersection of spirituality and health. And so I have the privilege of introducing Dr. Tammy Hannon. Dr. Hannon is a pediatric endocrinologist with specific training and expertise in nutrition science and diabetes research and clinical care. She is a professor of pediatrics at the Indiana University School of Medicine. She's the director of the Pediatric Diabetes Program and the Youth Diabetes Prevention Clinic at Riley Hospital for Children at IU Health. And she is currently an investigator on multiple projects that aim to improve patient-centered outcomes in strategies to prevent or treat diabetes, including an IU Values grant. So I'll let you take it from there, Tammy.
Thank you. Thank you very much, Alex. And I'm happy to be here talking with all of you. I'm going to share my screen. All right. Do you all see something that says youth onset diabetes?
We can see it.
All right. So I'm going to give you a little bit of background about youth onset diabetes. And when I trained as a pediatric endocrinologist 20 some years ago, the vast majority of my learning and teaching and experience with clinical care for youth with diabetes was type 1 diabetes. Type 1 diabetes is results from an absolute lack of insulin. It's principally an autoimmune disease where your immune system becomes tricked into thinking that part of the cells in your pancreas are foreign, and you lose the cells that make insulin, resulting in type 1 diabetes. In the past 20 years, there have been many reasons why type 2 diabetes has increased in young people. Type 2 diabetes is due to insulin that doesn't work very well to do what it's supposed to do. So the pancreas is still making insulin, but the insulin gets blocked at its target cells. And so you might have a lot of insulin, but it's not working well and you develop high blood sugar. Eventually, the pancreas does get sick and you lose the ability to make insulin. But that's the difference. Most kids who have diabetes have type 1 diabetes. And about 1 in 350 kids have a diagnosis of diabetes of either type by the time they graduate high school. So it's a common chronic disease of childhood, relatively common. However, in adults, 1 in 10, 1 in 9, probably in our state now, have a diagnosis of diabetes. So it's very common diagnosis in adults. In adults of high risk, so adults of certain genetic backgrounds, 1 in 2 will have a diagnosis of diabetes. About 1 in 20 youth have risk factors for diabetes have pre-diabetes, or a condition where blood sugars are high, but not high enough to diagnose the conditions. And COVID has increased the cases of type 2 diabetes related to the insulin not working well, due to weight gain and some other factors. The number of youth has increased by more than 100% in the past 2 decades since I became an endocrinologist, and by more than 150% during just the past 3 years. So this really, some centers now have about almost as much type 2 diabetes as they have type 1 diabetes, depending on where the practice is, like Los Angeles or in Philadelphia. Places like this have much more type 2 diabetes now than they did 20 years ago. We do as well, but not as much as those cities. It disproportionately affects marginalized youth with multiple adverse childhood events. We don't fully understand why this is the case. It's not because marginalized youth have more obesity. It's not because they have some genetic predisposition, though they may. There's something else at play there that we don't quite understand. And any kind of diabetes impacts mental health. And the reason I became interested in integrative therapies and more spiritual therapies in type 1 and type 2 diabetes is because we have good treatment for diabetes, and the treatment modalities have only gotten better, but our outcomes have not, particularly in teenagers. One reason for this is because diabetes is quite a burdensome disease to live with. So despite, the treatment improvements, we haven't reduced the number of tasks that you have to do to take care of diabetes. And in many ways, we've increased the number of tasks with the new technologies. So checking blood sugar used to happen when I first started twice a day, then 4 times a day, then 6 times a day, and now it's continuous. So standard of care to be continuously checking your blood sugar with a continuous blood sugar monitor. Your body needs insulin all the time. So in long-acting and short-acting insulins are given. You have to dose the insulin based on what you eat. You have to go to doctor's appointments and other appointments for your diabetes. You have to organize when and how you're going to get your prescriptions, how those are going to be paid for, how you're going to store those, and what supplies you need and when you're going to run out. And you have to have medicines that aren't expired. You have to remind your loved ones to take their insulin if your loved ones have diabetes, or you have to remind yourself. You have to set a lot of alarms to remind yourself to do things for your diabetes self-care. And when you sleep, you still have diabetes. So it doesn't end. You have to be educated all the time on new things that are happening and new problems that you might have developed related to diabetes. And many people with diabetes have to defend themselves constantly. You probably wouldn't be surprised. Kids with type 1 diabetes, type 2 diabetes, doesn't matter. They have to defend themselves to teachers, to law enforcement, to authority figures, to their parents, to their friends. They have to defend themselves to be, why are you doing that? Why do you need to do that? Why do it's never ending. Why are you eating that sugar? Well, you're not supposed. Did you get diabetes from eating sugar? It's just it's a lot. And in kids, we have a triad. We have the parent, we have the medical care team, and we have the patient in front of us. And there's a lot there. There's a lot of, I call it just clutter there, because there's there's technology, there's records, there's paper. If you've ever been to a diabetes visit, there's the doctor, and she or he has about 50 pages of paper in front of them, looking at all the numbers, looking at this lab test, that lab test. There's just a lot of clutter around, and there's less and less face-to-face, eye-to-eye, heart-to-heart, relationship building going on in medicine these days. So this is what a person with diabetes, a young person with diabetes, what they wear, what it looks like. A lot of times when they're taking insulin, they have insulin going in. And then they have a continuous glucose monitor that's measuring their blood sugar. And those two technologies can talk to each other, but they still need the person to control the computers. And then there's carb counting. And then there's looking at all of the never-ending data. Data is collected every second, every day, every night, every page after page of it. And this results in a lot of family conflict, personal conflict, internal conflict, conflict with your beliefs in the world, and it's a lot. It's a lot. It can be a lot. So I was interested in how to really use state-of-the-art diabetes care, but also really make this, learn about the person, make it personal, because a computer isn't really very personal, right? Talking about blood sugars and what you should do with your blood sugars isn't very personal. And we know that adolescents, of all the age groups, do the least well with their diabetes management. So when I say we, I mean me and other smart people taking care of kids with diabetes, came up with this framework that could be used to potentially buffer stress in adolescents with diabetes. And this particular slide says type 2 diabetes, but we've actually applied this to type 1 and type 2 diabetes. And so at the top, you see that adolescents, they have struggles with diabetes. And this applies to both kinds of diabetes, but that self-monitoring, self-acceptance, acceptance of others, fear of complications, trauma of the diagnosis, and needing a lot of social support. And then that leads to these skill groups that originally we wanted to integrate some skills groups, mind-body awareness skills groups, in with our diabetes education. And so there's some examples of activities for mind-body skills groups and the mechanisms by which they may buffer stress. We honed in on a couple of different activities and honed in further on a curriculum that focuses really on mindfulness, mostly mindfulness, in the context of a support group. So to increase social support and peer support, we delivered, where we're beginning to deliver a curriculum that's integrated into diabetes education along with social support, really teaching, practicing, and encouraging self-awareness, which we hope will improve self-efficacy and self-regulation skills. And ultimately, improve diabetes outcomes and quality of life for people who are living with diabetes. So this is the framework that we've applied for our research. And initially, we were working with the individuals from the Center for Mind-Body Medicine. We've transitioned, and we're working now with a researcher called Pat or Trish. She goes by Trish Broderick, who worked with one of the leaders in mindfulness-based stress reduction, John Kabat-Zinn, to develop a curriculum for mindfulness-based stress reduction called Learning to Breathe. And Learning to Breathe has 6 different basic themes. And the goal really is shown here in this picture of all the skills that you're going to work on during this. I have a link to a video there, but I'm not going to show it because I'm going to probably be going over time. But so we are in the midst of a pilot study. We've completed 2 groups, and we are going to complete 2 more groups. And in the groups that we've completed, we've recruited 60 participants. And in those groups, we've retained 29 participants, meaning they completed the 13 session group study. So that's 48% retention rate, with a pretty good attendance rate for adolescents, 57% attendance rate. And what we did, I'm going to show you a picture of it, but I'll just tell you what we did is this was a randomized controlled study where I delivered diabetes education in a group setting for 13 sessions to teenagers 14 to 17 years of age. And my partner delivered the Learning to Breathe curriculum along with diabetes education materials over the same time period. And then we measured the outcomes. So there were 13 hour-long sessions that we did over Zoom. And we randomized the participants to my group or her group. And we measured, this is pilot feasibility, so we measured really acceptability and feasibility. So in our acceptability data, it was acceptable to the people who attended. They reported practicing at home. They reported practicing more than we thought they would practice. Set around 80% practiced at home, around 70% practiced mindful thoughts, and a little over 60% practiced multiple Learning to Breathe skills over the course of the 13 weeks. We also provided some audio. The kids didn't use the audio so much, but they did report remembering and doing some practice at home, which is the whole point. Sorry, this is so small. Let me see. I don't know if I can increase the font. Sorry about that. But I don't even have to show that one really. So %. So I told you, we had like 29 people who attended the sessions and participated all the way through. 100% of them reported more than one area of life that they managed better because of their participation. 70% reported better ability to cope with stresses. The Learning to Breathe greater than the education only. 60% reported better ability to do diabetes self-care. And 55% reported better ability to control emotions. Learning to Breathe was better than education only for those 2 things. So we're pretty pleased with those initial outcomes. And then we also did some qualitative work where we had a focus group at the end, and we asked them to describe how they would advise a friend or family member about mindfulness and Learning to Breathe. And they gave us a good understanding of how it helped them by telling us how they might help others. And they were very enthusiastic about wanting to participate in telling us how we might revise the program the next time. I want to show you another, I just want to show you another picture because we're getting ready to do the next two, recruit for the next group. So we're working with Trish Broderick, who is the researcher who developed this curriculum. And she also introduced us to two researchers, one in Minneapolis and one in Colorado, who are developing a home practice app for the Learning to Breathe curriculum. And they're excited to partner with us to test this app so that we could better measure home practice. But this is what we've developed, and this is what our next part of our pilot will be focused on using, and then we'll write the next grant. So there are 13 sessions here, and the way we're going to break it down, because like I said, the first pilot was we had me doing the controls and Julie doing the Learning to Breathe, and they derive benefit from each group. And for certain things, they derived benefit from the other, and they all really liked the social aspect. So what we're going to do is we're going to combine it so that we do the curriculum that's true to the curriculum, so that we maintain affinity to the curriculum, but we also introduce a diabetes topic on alternate weeks and practice mindfulness around the diabetes topic. So if you can see here, the first topic in Learning to Breathe is body. The topics are body, reflection and thoughts, emotions, attention, tenderness, and health. So those are the topics. And then basically what we do, what we're going to do is we're going to do the curriculum as written, but on alternate weeks, we're going to do the curriculum, and then we're going to review the topic for the second week along with the diabetes education topic, and to see how they integrate together. So you see here, week 2, basic diabetes pathophysiology and symptoms. Week 4 will be high blood sugar sick days, and on from there. And then we have with the tenderness, which is really the most spiritual. They're all spiritual, but it's really the most spiritual. We have diabetes burnout, which is really a powerful session. So, I mean, I think I'm going to stop share. What I'm really excited about is I think this curriculum then could be offered on a national basis. I mean, we could offer it to people far and wide. We can publish the curriculum. I don't, because the first 2 groups of the pilot was so successful with regard to the kids participating and being enthusiastic about it and really having acceptance of the home practice. I think there's a lot of things that we could do with this curriculum. So I probably went over 15 minutes, so I'm going to stop there.
That's amazing work, Tammy.
Oh, and thank you. I did want to show a slide and I forgot to show it. Thank you for the funding, because the funding from the spiritual values grant has allowed us to do 2 more pilots, 2 more pilot groups, and also along with it do a separate interview-based qualitative study that does collect more data on spiritual practices, outside of this group. So we didn't introduce any other spiritual practices in these groups because we're really trying to stay with the Learn to Breathe curriculum. But our qualitative interviews will include that data, and we haven't started those interviews yet.
Great. And Tammy, I think you were slated or committed to 30 minutes, but we, have 30 more minutes in the hour. So up to you. If you have, some time for questions, then I'm sure some of the attendees would be eager to ask them, if that's okay with you.
Yeah, absolutely. And, I'm also excited about this curriculum and how it might be beneficial for parents as well. Parents separate from the kids, but parents have a lot of stress around their child's diabetes. Sometimes parents have diabetes themselves too. So that's another kind of avenue that's open.
Yeah.
Yeah.
Well, what questions do we have from those that are in attendance? Feel free to unmute and ask away.
This is Lexi. I've got a question.
Okay.
So thank you for that really great presentation. This work is so inspiring. And you may have touched on this a little bit, but could you talk a little bit more about what it's like to get teens to engage in mindfulness? And also, did you have to adapt the curriculum at all, or was it just right the way it was and the teens really got it? And what would you kind of advise folks who want to do mindfulness with teens as opposed to maybe older people or adults or any other population?
Mm-hmm. So fortunately for us, Learning to Breathe was developed for adolescents. So it was developed from a curriculum that was targeted to adult pain patients, actually, for use with adolescents, not with pain, but actually use with school age kids. So Dr. Broderick's goal was really to distribute her curriculum to schools and have teachers teach this in school. So the curriculum is really, really quite good for kids. Now, we didn't adapt it for the pilot because we wanted to maintain fidelity to the evidence-based curriculum. So we are adapting it now. So when I showed you the kind of the list, we're adapting it by adding sessions that incorporate the diabetes education. That's not really in the pedagogy of the Learning to Breathe curriculum. So we're seeing if we can stay in the spirit of the mindfulness and the attentive listening and center the education more. Well, I'll just tell you, diabetes education, if you've ever been through diabetes education, it's very didactic. It's very, I will tell you about diabetes, I will show you a picture, and then you will practice it once, and then you will go home and do it. That's diabetes education. That's, if somebody goes home and retains 30% of that, awesome. I mean, learning how to give a shot, then you practice and practice and practice. You have to do it every day. That's self-explanatory. You're going to be a professional at that. But knowing how to do the technical skills is not the thing. Knowing how to incorporate your diabetes self-care and be able to do everything you want to do in your life is a totally different thing. And people with diabetes learn from people with diabetes. Like, it's, they learn the most from their lived experience and talking with peers. And we know this is true because diabetes camp is one of the best ways to get kids diabetes control better. It doesn't improve during diabetes camp, it improves after diabetes camp because of all the support they've had and what they've learned from each other. And so the diabetes education coming in with it, it's not going to be like me telling you, okay, this is what it is. It's more like, here's our topic today. We're going to talk about sick day management. You know, here's an example. What would you tell your friend to do? And then they have a discussion about their life experience. And all the while we practice the components of mindfulness, which are pay attention right now with curiosity. And if they can pay attention right now with curiosity during the group, and they can transfer that to pay attention right now with curiosity during moments of their life, then we hypothesize that that would lead to a better life experience with diabetes. So that's the adaptation that we're doing, and we still have to pilot it. But getting kids to participate. So, I mean, you have to have some comfort with kids, and you have to know about adolescent development, I think, to probably be successful. But the good thing about this curriculum is that, you know, we're really maintaining fidelity. So it's all written out how you do the discussions and things. And so if you have those three, you're comfortable with kids, you got a group of kids that will talk and be on camera, and you follow the curriculum, then you'd be okay. I would also say that the leader has to do those things too, though. They have to pay attention with curiosity and, you know, be not judgmental. That's really important. And, you know, but it's also with kids and with any groups, adults too. The moderator also has to make sure that the information being put forward is helpful and not harmful.
Tammy, this is Marcos. Good to hear you and the good work that you're doing. I think I have two questions. I think the slide in which there were some percentages that you gave, and I think one of them was 60% of the participants reported improved coping with an aspect of diabetes care.
Yeah.
Specifically, did the data zero in specific aspects of the diabetes care? Was it the monitoring? Was it the insulin injections? Was it defending? What aspect of diabetes care did they report improvement?
Yeah, we asked them a number. So the one point that you're making is very good. So usually if you do an intervention in kids and then you ask them, oh, are you better? Do you check your blood sugars more? Well, most of them will say yes, so whether or not they do or not. And so you need to have some way, shape, or form of actually measuring that. So what we're doing is we're looking at 6 and 12-month hemoglobin A1Cs after their participation to see if their overall blood sugar control improves. We're also looking at something called time in range, which is from their continuous glucose monitors. If they wear them, we can just see on the computer printout what percentage of their blood sugars are in their target range. So we will have some harder outcomes, but we didn't have a lot of funding to get a lot of that data, and we didn't spend a lot of time on it because pilot feasibility, we just wanted to see if we could do it. So that'll be like the next grant that we send. It'll be important to make sure that we're measuring time in range. That's something that people in the diabetes funders, they care about that. And they also care about hospitalizations. And so we are going through the kids who participated, and we'll track them for the next year to see if they're hospitalized for an acute complication of diabetes. So that's what they did. And they mostly, you know, we asked them, did you increase self-monitoring blood sugars? Did you remember to give your insulin more often? They said yes, but I don't put a lot. I mean, I don't know, you know, most people will, I will say yes. If you give me an intervention and then I took my medicine yesterday, did you take your medicine more often? Well, yes, of course. I'll say yes.
That totally makes sense. Yes.
Yeah.
It's like, did you clean your room? That's what I asked my daughter. Yeah, sure, I cleaned it
Yeah.
this morning, but not the last couple of weeks.
Yeah.
My second question was related to maybe social media and apps. Any thoughts on the learning to breathe curriculum or any other form of the education being translated, converted into an app? Because I know, you know, nowadays there's an app for everything, and maybe that might help with retention and accessibility later on, beyond the mindfulness or diabetes education session.
Yeah, I'm cautiously optimistic that it could be useful. There is an app under development for research purposes that we're going to use when it becomes available. When we've tried to use apps previously for different things, kids, I mean, adolescents use apps for social interaction. They don't use apps much to monitor their diabetes self-care. So I did a study about 10 years ago where we used this app-based blood sugar tracker. And the parents were all excited about it, of course, because everybody would know what the blood sugars were and the kids would get better. And the kids never used it. The kids hated it. They didn't charge it. They just really are involved in their social interactions. And so we'll see if they use the app. And I think, reminders to practice could potentially be helpful, but I'm cautiously optimistic about that. Like if you load on the Calm app, they're not going to use it.
Tammy, I have a few reflections in the question. One is your talk reminded me of learning body scan when I was a fellow in pediatric hematology oncology. And I remember it was an attending who pointed me to John Kabat-Zinn, and it was really helpful to me being aware of like tension in my shoulders or in my body after delivering bad news in pediatric oncology. And as I thought about that, I think about how if we as clinicians have experienced a spiritual practice or an intervention that's helped us, we're more likely to utilize that or recommend that for a patient. Is there any knowledge or idea about mindfulness in pediatric endocrinology? Do pediatric endocrinologists in general have experience with mindfulness?
Well, it's a good question. I don't know if anyone knows the answer. I recently gave a talk at University of Chicago, and I was meeting with people after the talk, and they had me meet with an adult endocrinologist who I didn't know, but the reason why they had me meet with her is because she's a meditation teacher, and so we were talking about it. I don't think so, but what I will say about that is I have a meditation teacher who in Australia who told me, we were having a talk about ethics, and she told me she hates when she's hired to go teach at health companies or medical centers, because usually it's because there's a lot of burnout, and the need for this wasn't generated by the healthcare providers, but it was imposed on them, and that's not well received. And she, so that's, sort of gaslighting the people who are burned out, which I think is a fair assessment. And I think about that too, with using this in people with chronic disease, as I don't ever want to suggest that this is, you just need to be mindful and you could do so much better, right? But having said that, I think if people come and say, I want to try this and see if it could help, then yeah, I think all the healthcare professionals should have that option, right? I think that you're right. When it's worked for you, you think, oh, I'm going to teach this to somebody else, and then I think you have to check yourself, because you have to say, am I offering something that this person wants, needs, is this for me or is this for them,
I love the balance in your statements. It's very, very right on the target. So. Anybody else with questions or thoughts, reflections?